Hello, this is Ciaran Kelly. I hope you're having a good conference. I'll be speaking to you on celiac disease, which is one of my absolute favorite topics. Celiac disease is prevalent worldwide. This is a meta-analysis of the prevalence of celiac disease in different continents. We have data here from every continent except Antarctica, where we were not able to find any data. So if we start with North America, we can see that the serologic prevalence of celiac disease is 1.4% based on a meta-analysis of the published data. The histologic prevalence is quoted as being lower at 0.5%, but it's important to note that wherever histology data was not available, it was assumed to be negative. And so the histologic prevalence estimate is an underestimate of the true prevalence of celiac disease. The serologic prevalence estimate is probably more accurate. So let's compare that to other parts of the world. Well, in Europe, the prevalence is almost identical to that in the United States. So the idea that celiac disease is more common in Europe is not actually supported by the current data. There are also very similar prevalences in South America and in Australia. In Africa, the prevalence is slightly lower. It's important to note here that most of the data from Africa come from Northern Africa, and the prevalence in sub-Saharan Africa is not really well known and is possibly lower than in other parts of Africa. In Asia, most of the prevalence data comes from India, where there's a high prevalence of celiac disease, particularly in northern India, where wheat is a staple cereal. Other parts of Asia may have lower prevalence, such as China and Japan, but we have poor data from those areas. Overall, however, the serologic prevalence of celiac disease is at or above 1%. So is this high prevalence of celiac disease? I should note that back 20 years ago, the quoted prevalence of celiac disease in the United States was not 1%, but 0.02%. And so there has been a dramatic shift in the estimated prevalence of celiac disease in recent decades. So is this a real shift, or is it simply related to diagnosis, the facility of diagnosis using accurate celiac serologies? Well, this study suggests that there's been a real increase in incidence of celiac disease. The study began with 900 sera taken from healthy young adults at Warren Air Force Base around the year 1950. And testing of these sera indicated a prevalence of celiac disease of 0.2% in terms of positive IgA TTG. Controls were evaluated from 13,000 gender-matched subjects from two recent US cohorts. And these cohorts were matched for the cohort from Warren Air Force Base in two ways. The first matching was by year of birth. And so these would be samples from individuals who are now approximately 70 or 80 years of age. And the second was sampling at similar age of sampling. And so these were samples taken from individuals at approximately 20 to 25 years of age. And both of these control cohorts yielded a prevalence of celiac disease by serology of 0.9%. Interestingly, the mortality hazard ratio in individuals with undiagnosed celiac disease from sera taken in 1950 was 3.9. So having a positive IgA TTG was associated with an increased mortality risk. So celiac disease appears to be 4 times more common now than it was 50 years ago. There's also a fourfold increase of death associated with undiagnosed celiac disease over a 50-year time period. Whether those deaths are celiac related or whether they're related to other immune mediated conditions or infections is not clear. So how does celiac disease present? Well, those of us who work in the clinic, I think, are now well aware of the protein clinical manifestations of celiac disease. Common features include nutritional deficiency states, particularly iron deficiency anemia, as well as gastrointestinal symptoms such as diarrhea, abdominal discomfort, and bloating. In children, there are similar features, including failure to thrive. There are, however, a myriad of less common features, and really these span all systems, everything from orthopedic to osteopenia, osteoporosis, dental enamel hypoplasia, recurrent after stomatitis, etc. And there's a long list. In fact, my professor in Ireland always quoted that celiac disease can present at any age and to any medical specialty. So it doesn't matter if you're an orthopedic surgeon, a pediatrician, a primary care physician, a neurologist, an endocrinologist. Celiac disease can present to you with some of its manifestations. There are also a long list of associated conditions, most of these being autoimmune or immune mediated. And finally, celiac disease can present with severe complications, including refractory sprue or enteropathy associated T cell lymphoma. Fortunately, these severe complications are rare, as we'll discuss later in the talk. So, a pop quiz for you. What is the most common or the average age at diagnosis of patients with celiac disease in the United States? Is it around 5, around 15, around 25, around 35, or around 45 years of age? Well, the actual answer is 45 years of age is the most common or the average age of presentation. And so celiac disease, as I've shown you from the world prevalence, is common in many ethnic backgrounds and can present at any age after the onset of gluten ingestion. Although the average age is 45 years, it can be anything from 2 years to, and I've diagnosed patients in their 90s, typically presenting with anemia. There are highly diverse clinical presentations, and perhaps because of this, one survey study showed that the interval between the onset of symptoms and the diagnosis of celiac disease averaged 11 years, with a 6-year interval between the patient presenting those symptoms to a healthcare professional and the diagnosis. So it is not surprising, given the protein clinical manifestations, that there may be delay in diagnosis. So awareness of this is important for diagnosis of the disease. So how do we approach diagnosis? Well, in current practice, we use celiac-specific serology as the first step in diagnosis or exclusion of celiac disease. The old anti-Gluten antibody tests, which we used for many years, are no longer used. This is because they have a very low positive predictive value. In other words, they have a high false positive rate. In place of regular anti-Gluten antibody serologies, we now use 2 sets of serologies, the most common being IgA anti-tissue transglutaminase, which has a high sensitivity and specificity and a high diagnostic accuracy. The endomysial antibody is slightly more specific, but not quite as sensitive as the IgA-TTG, and this is an immunofluorescence assay and is much less available than the ELISA type assays that are used to measure IgA-TTG. There's one other set of antibodies that are worth being aware of, and that is deamidated gliadin peptide. And so what the background here is that native gluten peptides adhere to or bind to the peptide binding groove of HLA-DQ2 or HLA-DQ8. And when bound to the groove, they are presented to gliadin-specific T cells to activate a celiac T cell reaction. When the native gliadins are deamidated by tissue transglutaminase, their fit in the antigen binding groove is increased 100-fold. And this results in 100 to 1,000-fold increased antigenicity and potency in activating a T cell response. So with this knowledge, the old substrates used for anti-Gluten antibody testing, which was native gliadin, which had approximately 75% diagnostic accuracy, have been replaced by deamidated gliadin peptides. And these deamidated gliadin peptides, or DGPs, have a higher diagnostic accuracy than the old anti-gliadin antibody. So IgA-TTG remains the best and the primary serologic test for celiac disease. But under what circumstances should we consider also testing for deamidated gliadin peptides? Well, a common indication previously was a positive anti-gliadin antibody serology with a negative TTG. And this was common because the AGA antibody tests, as I mentioned, had a high false positive rate. This is less common now with the availability of deamidated gliadin peptides and the fact that regular anti-gliadin antibody testing is less commonly performed. Another situation is where a patient has a positive TTG, but for some reason one is unable to confirm a diagnosis of celiac disease by histology. Perhaps the patient refuses biopsy, or biopsy cannot be performed for some other reason. An example of this was a patient that I had who had a strongly positive TTG during the second trimester of pregnancy. And because of her pregnancy, she decided to delay endoscopy with biopsy. So this was a situation where performing deamidated gliadin peptide serologies, which were also strongly positive, provided a backup positive result to the TTG, making the reliability of the serologic diagnosis stronger. In patients who have IgA deficiency, IgG deamidated gliadin peptide is the go-to test to identify celiac disease. The practice of performing IgA-TTG in combination with a total IgA is commonplace, but it has been suggested that instead of doing total IgA as a second test, the second test might more effectively be an IgG DGP, because this would circumvent the issue of IgA deficiency and also provide a second measure of celiac serology positivity. So here we have a case history. It's a 68-year-old man diagnosed as having celiac disease 14 months ago when he presented with diarrhea and weight loss. Duodenal biopsies showed partial villus atrophy, as well as an increase in intraepithelial lymphocytes. His serum IgG-AGA, so the old-fashioned anti-gliadin antibody test, was positive, but serum IgA-TTG was negative with a normal total IgA. He has not improved on a strict gluten-free diet. The question is, which of the following diagnostic tests would you recommend doing next? Would you repeat the IgG-AGA? Would you do HLA-DQ2-DQ8 typing? Would you repeat a small intestinal biopsy to see if he has healed on the gluten-free diet? Or would you do hydrogen breath testing for bacterial overgrowth? Well, all of those tests are reasonable, but the most useful is to perform HLA-DQ2-DQ8 typing. Repeat serum IgG antigliadin is prone to the same false positives as previously. The repeat biopsy will not be helpful unless it shows complete healing, which is not likely to occur, but could occur. And hydrogen breath testing seldom causes such severe histologic injury as to be directly confused with celiac disease. So what is the background to HLA-DQ2-DQ8 typing? Well, in patients with celiac disease, almost 100% are positive for HLA-DQ2-DQ8. And so this test has a very high negative predictive value if it is negative. However, in the general population, 40% are positive. And so the positive predictive value of HLA-DQ2-DQ8 is very low. Overall, then, in a word, DQ2-DQ8 testing is excellent at excluding celiac disease, but cannot be used to diagnose it. In this particular case that I presented, DQ2-DQ8 was negative, and so this allowed us to determine that this patient had a non-celiac enteropathy. It turned out the patient had an autoimmune enteropathy, not celiac disease. So who do we test for HLA-DQ2-DQ8? Well, I think the one prime example is a patient such as this, where there's a disagreement between histology and serology, in particular, villus atrophy, but IgA TTG negative prior to starting the gluten-free diet. If the serology is positive, then the standard of practice is to perform endoscopy and obtain small bowel biopsies. It's important to obtain multiple biopsies, a total of 6 to 8 in the second and third part of the duodenum. And this is because the disease can be patchy. Whether or not to also perform duodenal bulb biopsies is under discussion. It does appear to increase the sensitivity of celiac disease diagnosis, but this may be associated with some loss of specificity because of non-specific villus changes in the duodenal bulb, as well as the presence of inflammation caused by peptic duodenitis, which can lead to false positive results on histology. And so it's important when interpreting duodenal bulb biopsies that it's an expert GI pathologist. The macroscopic features of celiac disease on endoscopy are listed here. These have a relatively poor sensitivity for celiac diagnosis, but a moderate specificity. And so if one suspects celiac disease and sees these changes, one should take a biopsy to confirm the diagnosis. If one suspects celiac disease and does not see these changes, then one should take a biopsy to confirm or refute a diagnosis of celiac disease. So either way, the pathologist gets the final say. In reporting pathology, it has become increasingly common for pathologists to report a so-called MARSH1 lesion. That is where there is no villus atrophy, but there is an increase in intraepithelial lymphocytes. And this is a sensitive and early test or change in celiac disease, but it is not specific. And increased IELs occur in a wide variety of other conditions, including common conditions such as H. pylori infection, NSAID use, or acid peptic injury. And so an increased IEL of its own accord is not diagnostic for celiac disease, although in my practice it would certainly prompt testing for IgA TTG. So what to do when the tests disagree? If the TTG is positive, but the biopsy is normal, I would ask whether a accurate human-based TTG assay was used, and I would check for DGP antibodies. I would ask the pathologist to review the biopsy for subtle changes of celiac disease. I would ask if the patient was really on a regular gluten-containing diet or had they reduced their gluten intake. And I would consider obtaining additional biopsies in case the disease is patchy and mild. There's also, however, a condition called potential celiac disease, where there is repeated positive celiac-specific serologies, particularly positive IgA TTG, but the biopsy is normal. And potential celiac disease is considered to be on the spectrum of celiac disease. If the patient has signs or symptoms consistent with a diagnosis of celiac disease, such as diarrhea, bloating, evidence of malabsorption, then a gluten-free diet is indicated. But if they are asymptomatic, then the patient can be managed on a regular diet but monitored. Only a minority of these patients go on to develop overt celiac disease, perhaps in the order of 10%. What about the opposite, where the TTG is negative, but the biopsy shows villus atrophy? Well, here I would measure total IgA, I would measure IgG, DGP, I would test HLA-DQ2, DQ8, as in the clinical example that we just discussed. And I would consider a non-celiac enteropathy and obtain expert review of the histopathology. There may be clues on the histology that might point to another diagnosis. Here are photomicrographs of 2 patients with diarrhea and bloating. Question is, which of these cannot eat gluten? The answer is neither can tolerate it. And that is because the patient on the left with normal histology has so-called non-celiac gluten sensitivity. And this is a study which really put this condition on the map. The study included only patients where celiac disease was definitively excluded because they had negative serology and negative biopsies on a normal gluten-containing diet. However, these patients reported symptoms on gluten ingestion, and this study involved a double-blind, randomized, placebo-controlled trial where patients were challenged either with gluten or with placebo. What's shown here is a visual analog scale of the patient's reported symptoms following or during the challenge. As you can see, there was some increase in symptoms with placebo, or what might more accurately be described as a nocebo challenge, but the increase in symptoms was greater in patients who were challenged with gluten. And these differences were significant for overall symptoms, but also for abdominal pain, bloating, tiredness, and satisfaction with stool consistency, whatever that might entail. So this suggests that non-celiac gluten sensitivity is a real phenomenon. But I will add the caveat that the food intolerance may not be to gluten per se, but maybe to foods that are, or substances that are present in gluten-containing foods, such as FODMAPs. It also clearly demonstrates that one cannot make a diagnosis of celiac disease based on intolerance to gluten alone. That is symptomatic intolerance. It requires confirmation by serology and or histology. So what is the status of patients on a gluten-free diet in the United States? Well, this is a study from perhaps 10 years ago now, which looked at the seroprevalence of celiac disease. At the time, it was believed to be a little less than 1%. As I just shown you, it's now believed to be higher at a little more than 1%. And at the time, it was estimated that there were 2 million patients in the US on a gluten-free diet and 2 million patients with celiac disease. But there was only a small crossover. There was only 300,000 patients who had both celiac disease and were on a gluten-free diet. So the conclusion is that most patients with celiac disease were undiagnosed at this time. The rates of diagnosis have increased somewhat over the past 10 years, but they are still less than 50%. Conversely, most patients on a gluten-free diet did not have celiac disease. So our next case is a 46-year-old woman who reported previous abdominal pain and bloating and was diagnosed as having IBS. She'd not lost weight and did not have diarrhea. She self-prescribed a gluten-free diet and has been taking a gluten-free diet for 9 months with some but not complete improvement in her symptoms. Her labs, including nutritional profile, are normal. Her IgA-TGG was negative, but remember that she is now on a gluten-free diet. She asks if she has celiac disease because she wants to know if her children should be tested. So which of the following tests would you recommend for her? Would you see if there's a symptom response to gluten ingestion? Would you request endomysial antibody testing? Would you initiate a formal gluten challenge followed by endoscopy with biopsy? Would you perform genetic testing for DQ2, DQ8? Or would you perform DGP serologies? Well, in this circumstance, I would recommend, again, performing genetic testing. And indeed, this is the most common indication for genetic testing in my clinical practice. And that is when patients who have not been adequately diagnosed as having or excluding celiac disease present already on a gluten-free diet and seek a diagnosis. A symptom response to gluten ingestion, as I showed you, is not a reliable indicator of celiac disease. The endomysial antibody is less sensitive, although a little more specific than TTG, and so is not likely to be positive. A formal gluten challenge is certainly indicated if the patient is positive for DQ2 and DQ8. But if they are negative for DQ2 and DQ8, then a formal gluten challenge can be avoided. And the amidated gliadin peptide antibody will also turn negative on a gluten-free diet, and so is less reliable in this circumstance. And so this is the second major indication for performing HLA DQ2, DQ8 testing in a patient such as this on a gluten-free diet without prior diagnostic testing. And as I mentioned, this is the most common reason for me to order DQ2, DQ8 testing in clinical practice. So back to non-celiac gluten sensitivity, we have a picture here of two dudes driving by the beach, and one says to the other, I have no idea what gluten is either, but I'm avoiding it just to be safe. And this refers, of course, to the lifestyle preference of adhering to a gluten-free diet in the absence of any diagnosis of celiac disease. So is this helpful or not helpful for patients with celiac disease who are following a gluten-free diet? Well, I think it has led to more awareness of the gluten-free diet and easier access to the gluten-free diet. It probably has not led to a substantial reduction in costs. Gluten-free foods are typically twice or even three times more expensive than their gluten-containing alternatives. However, there are some cons for patients with celiac disease, and the main con is that following a gluten-free diet may be considered a lifestyle choice rather than a medically necessary treatment, and there can be inconsistencies in strictness. For example, an individual who has made a lifestyle choice to follow a gluten-free diet may order their entree from the gluten-free menu, but then order a gluten-containing dessert of apple pie and ice cream. And this causes confusion and a lack of clarity for the wait staff and the kitchen as regards how strict to be in preparing the gluten-free foods. I have a patient who was asked by a waiter when they asked for the gluten-free menu, was asked by the waiter if they had biopsy confirmed celiac disease or not. I guess an indication to the chef that they needed to be particularly careful if there was indeed biopsy confirmed celiac disease. So how can we differentiate, apart from looking for a negative DQ2, DQ8, how can we confirm non-celiac versus celiac disease? Well, the most useful is a positive celiac-specific serology at any time, but particularly before the patient starts a gluten-free diet. Conversely, if the patient has negative celiac serologies on a regular diet, this is very helpful in excluding celiac disease. Are there other pointers to the differential diagnosis? Well, in this study, which we performed on our patients, we found that age and gender did not differentiate celiac from non-celiac diagnoses, but there were differences in terms of typical symptoms, family history of celiac disease, the presence of other autoimmune conditions, and the presence of any nutritional deficiency, all of which were significantly more commonly found in those with celiac disease compared to those without. So this slide is to introduce us to or reintroduce us to the concept of villus height to crypt depth ratio. So the height of the villus is illustrated here and the depth of the crypt. And normally the villus is approximately twofold taller than the crypt is deep. But this ratio is disturbed in celiac disease because of a reduction in villus height and an increase in crypt depth. And so in patients with celiac disease, villus height to crypt depth is typically less than 2 and maybe as low as 1. So how does this change with gluten challenge? In this study, we showed that there was a significant reduction in villus height to crypt depth ratio after 2 weeks of gluten challenge, as shown by this graph of villus height to crypt depth ratio. This reduction in villus height to crypt depth occurred whether or not we used a high dose or a low dose of gluten. The high dose gluten was 10 grams per day and the low dose was 3 grams per day. And by way of perspective, a typical slice of bread is approximately 2.5 grams. So a typical portion of gluten-containing foods accounts for about 2.5 grams. So you can see here that the low dose was a generous portion of gluten once a day, whereas the high dose would be as much as 3 or 4 portions of gluten per day. But both showed a similar reduction in villus height to crypt depth ratio, although the lower dose gluten was better tolerated by the patient. What about serology? Well, serology is different. It did not increase during the 2 weeks of gluten challenge in this study, but actually rose after the gluten challenge has ended. And so when looking for serologic response to gluten challenge, it's important to wait at least 4 weeks until performing these serologies. And this is true for IgA, TTG, and is also true for DGP, where there's also a later increase in serology compared to symptoms which occur early, histology, which can be seen as changing in as little as 2 weeks, whereas serology takes a month to rise. So some pointers as regards performing a gluten challenge. The first key point is to seek serology before the patient starts a gluten-free diet. And this is very important whenever a diagnosis of celiac disease is suspected. If the patient did not have adequate testing before starting a gluten-free diet and they are now serologically negative, a genetic test can be helpful as it can obviate the need for a gluten challenge. That is, if the patient's DQ2, DQ8 negative. And this occurs in about 40% of patients who present as the second patient of ours presented, asking about a diagnosis when they were already adhering to a gluten-free diet. A lower dose of gluten may be helpful in avoiding severe symptoms of challenge. And I tend to tell patients to start with one portion of gluten per day, for example, one slice of bread, and then to gradually increase over the course of 3 or 4 weeks to a full dose of gluten, which is approximately 3 or 4 slices of bread per day, or the equivalent in cups of pasta. There's an option for a 2-week challenge. So I always tell patients if they can tolerate the gluten challenge for 2 weeks, then it's worth performing a biopsy at that stage. But I always encourage them to continue for an additional 6 weeks for a total of 8 weeks of gluten challenge. And then after they've been on gluten for at least a month, then I will perform celiac serologies. So this is the expected desired response that patients, when they start a gluten-free diet, will show an improvement in symptoms, and this occurs quite early. And this will be followed by normalization of their celiac-specific serologies and healing of the lesion on biopsy. But this does not occur in all patients, and so-called non-responsive celiac disease is quite common, where there are ongoing signs or symptoms despite at least 6 and more usually 12 months of a gluten-free diet. And this afflicts about 10% of celiac patients overall. So why does this occur? Well, there are several reasons. One is the patient may not have celiac disease. The second is they may not really be on a gluten-free diet. The third is they may not just have celiac disease. There may be a second diagnosis driving their symptomatology. And thirdly, the celiac disease may not be gluten sensitive. They may have so-called refractory celiac disease. So let's look at each of these possibilities in turn. The first, where it is not celiac disease. These are patients with a case series that we published on patients with non-celiac villus atrophy, showing the diagnosis, the most common being immune-mediated non-celiac enteropathy. But there are other diagnoses. As I mentioned already, peptic duodenitis can cause confusion, particularly with duodenal bulb biopsies. And there are other conditions such as collagenous sprue that can be misdiagnosed as celiac disease. In this case series, almost all of the patients had been misdiagnosed initially as having celiac disease because of the findings of villus atrophy and inflammatory changes on biopsy. The key here is that these patients are TTG and DGP negative on a normal gluten-containing diet. About 40% of them are DQ2, DQ8 negative. Second possibility is that the patient is not really gluten-free. This is a survey study where were asked about intentional exposures to gluten as well as inadvertent exposures to gluten. And only 30% of the respondents to the survey felt that they had no intentional or known exposures and no inadvertent lapses over the previous month. Most felt that either there was inadvertent or there was purposeful exposure to gluten. So we looked at this more objectively in this study, which we call the doggy bag study, for reasons that will become clear. It was a prospective study that we performed in Canada in patients in Canada who had been on a gluten-free diet and were following it strictly for at least 2 years. We asked these patients to provide us with a 10-day sample of food as well as samples of stool and urine. So the providing us with 25% of all of their food plates gave the study the name the doggy bag study. And then we measured gluten in the food, stool, and urine using gluten immunogenic peptide, which relies on a gluten-specific monoclonal antibody. And these are the findings. Overall, you can see that a significant percent of the samples that we tested had the presence of gluten. And overall, 66%, so 2/3 of the subjects, had at least one positive sample during just the 10 days of study. So this would suggest that exposure to gluten is common in patients who are carefully following a gluten-free diet. And this is not surprising when you think about how ubiquitous gluten is and how difficult it can be to maintain a gluten-free diet. It's especially difficult when one is eating outside of one's own home. So at social events or when traveling, when eating in restaurants and cafeterias, or when eating takeout food, whenever one is not in control of the food that one is imbibing. It's also difficult for the elderly to begin following a gluten-free diet because they have to change their practices of a lifetime in terms of the purchasing and preparing their foodstuffs. It's extremely difficult for illiterate patients who cannot read labels to determine if there's gluten in the food. It's also difficult for those with mental or psychological impairment, as well as those of limited means, because gluten-free foods tend to be more expensive than gluten-containing foods. To further complicate matters, gluten is present as a hidden source in many, many areas. Here are some examples. There may be gluten in toothpaste. If one licks envelope gum, there may be gluten present in the gum, may be present in lipstick, candy, and flavorings, and even in medications and supplements. And to further complicate it, grains or cereals that are naturally gluten-free may become contaminated, either in the field because there is wheat, barley, or rye growing in the field or nearby, or during harvesting, transport, and processing. In this study, naturally gluten-free cereals were tested for gluten, and you can see that there was substantial amounts of gluten present in millet flour, as well as in sorghum flour and in soy flour, which should be naturally gluten-free. In this particular study, one of the samples of soy flour that was tested had approximately 3,000 parts per million of gluten. What's considered a safe level is 20 parts per million. And so I have many patients who believe that they have developed soy sensitivity as part of their celiac presentation. And this is likely that they're sensitive not to soy itself, but to gluten contamination of the soy flour. Second question patients often ask is how much is too much gluten? So this study looked at that question by performing a so-called gluten micro challenge of 50 milligrams. You remember the study I showed you earlier, we used 3 or 10 grams of gluten per day. So this was a micro challenge with much less gluten. The villus height to grip depth ratio was used as the primary measure in this study. As expected, Well-treated patients with celiac disease had a villus height crypt depth ratio of approaching 3. Treated celiac patients had a lower villus height to crypt depth ratio compared to normal controls. And this may reflect the presence of small amounts of gluten contamination, despite their best efforts in following the gluten-free diet. But with the micro challenge of 50 milligrams per day, there was a deterioration in histology over the 90-day study period. So to place this in perspective, 50 milligrams of gluten is equivalent to 1/40th of a slice of bread. So very small amounts of gluten are sufficient to perpetuate the changes, the histologic changes of celiac disease. So how do we evaluate whether or not a patient is effectively avoiding gluten in their diet? Well, it's not easy. Patient report is the first step that we take. We developed a validated celiac disease adherence test, and this consists of several questions about the gluten-free diet, but the two questions that we found to be most useful were asking the patient when they last cheated, in other words, when they had a purposeful ingestion of gluten last. And the second question that we found useful was the patient's confidence in their ability to follow a gluten-free diet when eating outside of their own home. So these are two useful questions to ask patients with celiac disease to get an initial quick evaluation of their adherence to a gluten-free diet. Serology is helpful if it is positive, but much less helpful if it is negative, as it is not sensitive to small amounts of gluten exposures. In terms of the trajectory of celiac serologies on a gluten-free diet, I expect the serology level to drop by about 50% every 2 to 4 months. So if a patient starts with a TTG of 100, after 2 to 4 months, I'd expect that to have dropped to 50, 25 after another 2 to 4 months, and be down in around the normal range after a year. However, patients vary. Some patients begin with much, much higher TTG serology levels, and some patients will fall, the serology will fall more slowly or indeed more quickly. The gold standard is an expert dietitian evaluation of the gluten-free diet. Histology is helpful, but it is more a measure of disease activity rather than gluten-free diet adherence, because some patients are more sensitive to small amounts of gluten than other, and they may have persisting histologic changes despite their very best efforts to follow a gluten-free diet. It is possible, as I showed you from the study that we performed, to measure gluten in stool and in urine and in food, but this is largely confined to research studies. So the next reason for non-responsive celiac disease is that the patient may not just have celiac disease. This is a study of patients with non-responsive celiac disease, where we list here the other diagnoses that were made. The most common reason, of course, is gluten exposure, but many of these patients have other diagnoses such as IBS or microscopic colitis, or in a minority, refractory celiac disease. And in refractory celiac disease, there's persisting symptoms and histologic abnormalities despite a strict gluten-free diet. This is a study of refractory celiac disease in our patient cohort. Overall, we found that 4% had refractory celiac disease, but many of these had been referred from outside institutions, and so there was referral bias that falsely elevated the rate of refractory celiac disease. When we looked only at individuals from, so in network, we might say, who were diagnosed and managed within the BIDMC system, the rate of refractory celiac disease was much lower at 1.5%. And that's probably a more accurate estimate of the true prevalence of refractory celiac disease. So 10% non-responsive, 1 or 2% refractory. It's important with refractory celiac disease to differentiate so-called type 1, which is the less severe form, from type 2, which is the more severe form. This immunohistochemical micrograph shows cells that are positive for the T cell marker CD3, and you can see intraepithelial lymphocytes that are positive in the upper left panel. And in the upper right panel, you can see that there are also lymphocytes that are positive for this T cell differentiation marker, CD8. In the lower left panel, you see that in this patient with type 2 refractory celiac disease, the CD3 positive intraepithelial lymphocytes are again shown. But in this instance, there's a dearth of CD8 positivity, and less than 50% of the CD3 positive cells are also showing positive for the differentiation marker of CD8. So these are undifferentiated IELs or aberrant IELs, which can be shown by immunohistochemistry, FACS analysis, or T cell receptor PCR. The importance here is that the survival rate of patients with type 2 refractory celiac disease is substantially lower than those with type 1 refractory celiac disease. In Europe, where these studies were initially performed, type 1 refractory celiac disease is seldom diagnosed, and most of these studies were in patients with type 2. This is probably related to referral bias because the study was performed at centers that specialize in the management of refractory celiac disease. In our studies, we find that type 1 refractory celiac disease, the less severe form, is more common. There was zero mortality in that population in our study, as opposed to type 2, which we found in 15%, and there was a significant mortality rate in our patients with type 2 refractory celiac disease. So how do we manage refractory celiac disease? Obviously, the patient must carefully adhere to a strict gluten-free diet. It's important to look for nutritional deficiencies in these patients, and particularly patients with type 2 refractory celiac disease will sometimes require TPN. Immunosuppression is used, and we now initially use enteric release budesonide for the management of type 1 and type 2 refractory celiac disease. Budesonide, Entocort, and enteric release budesonide, small intestinal release budesonide, is more likely to be effective in type 1 refractory compared to type 2. In type 2, we may need to look at immunosuppressive therapies or even biologics to try to control the disease. This is an excellent review, modesty aside, of the guidelines for diagnosis and management of celiac disease. In these guidelines, there is an algorithm for the evaluation of non-responsive celiac disease. Step 1, make sure it's celiac disease. Step 2, dietitian evaluation to make sure the patient is indeed gluten-free. If they are, do a small bowel biopsy. If there's no persisting villus atrophy, but the changes of celiac disease have healed, then one considers diagnoses such as irritable bowel or other food intolerances or bacterial overgrowth. If there is persisting villus atrophy, think about the other causes of villus atrophy. And if those are not present, then consider refractory celiac disease and determine if there are aberrant T cells, making a diagnosis of either type 1 if there are no aberrant T cells, or type 2 if the aberrant T cells are indeed present. So to summarize, are some take-home points. Celiac disease appears to be increasing in prevalence pretty much worldwide. Non-celiac gluten sensitivity is common. If the patient presents already on a gluten-free diet, the first step is HLA testing. If HLA testing is negative, then one can essentially exclude celiac disease. But if it is positive, then a gluten challenge is needed. Non-responsive celiac disease is common. It has multiple etiologies, the most common being errors in the gluten-free diet, the first step being a dietary evaluation, and other interventions being testing for TTG. A positive TTG suggests persisting gluten exposure, and repeat biopsy to determine whether or not there is healing or persistent villus atrophy, which might indicate the presence of refractory celiac disease, with type 2 refractory celiac disease with aberrant T cells being less common, but far more severe than type 1. And refractory celiac disease must be differentiated from the other causes of non-responsive celiac disease. And so I will leave you with some pictures of healthy villi and villus atrophy, and I thank you for your attention.